Hello everybody. I'm sorry I can't be with you here in Vienna, and I hope you're enjoying the conference and the city. I'm an endocrinologist, and our unit is part of a joint research group of the cardiology division and the endocrinology unit. We are engaged in research on the mutual effects of endocrine diseases and cardiac diseases. Today, I would like to focus on the impact of thyroid gland function on the heart, with an emphasis of the connection between thyroid dysfunction and heart diseases. I will provide an overview of the topic and share our experience regarding this area. This is my disclosure. Thyroid dysfunction is associated with increased cardiovascular morbidity and mortality. The prevalence of overt thyroid dysfunction in adults is estimated as 5 to 6%, and including subclinical thyroid dysfunction, the prevalence exceeds more than 10%. There is growing evidence regarding the occurrence of thyroid dysfunction in cardiac patients and the effect of these disorders on their medical status and prognosis. Cardiac manifestations of thyroid disease are many, and we can see it in hypothyroidism and hyperthyroidism. For hyperthyroidism, anginal symptoms we see, and tachyarrhythmias, heart rate, and others. And for hypothyroidism, we see the peripheral edema, the cardiac output problems, also the heart rate, and the problems with the contractility, etc. And as you can see here. The pathophysiology includes influence of thyroid hormones on the endothelial function, myocytes, lipid metabolism, heart rate, and cardiac output, and more. In light of the paucity of research data regarding thyroid dysfunction in cardiac hospitalized patients, we undertook a study in this population to gain a clearer understanding of the scope of the issue and to improve the management of these patients. You can see here the aims of this main study. Aims were estimation of thyroid dysfunction in hospitalized cardiovascular patients, characterization of patient groups with high prevalence of thyroid dysfunction, and investigation of the association between thyroid dysfunction and clinical outcomes. At our hospital or medical center, we have a big cardiology division with a TSH screening test that we do for all non-elective patients at the first day of hospitalization. So we collected the data for all the adults hospitalized patients at the cardiology division between 205 and 217. For patients that had multiple hospitalizations during the research period, we took only the first screening result. We investigated the patient's clinical characteristics as well as outcome. Two main outcomes: length of stay or length of hospitalization, and mortality during our research period. You can see here the categories, the TSH categories that we used for this trial, for this research. Normal TSH result in our lab is between 0.35 to 5, and higher or lower considered thyroid dysfunction. So thyroid dysfunction was all the others beside the normal range. Okay, you can see here 5 categories. the two of the hyperthyroidism called overt and subclinical or mild hyperthyroidism. And by the hypothyroidism, we used also overt and subclinical or mild hypothyroidism. Let's see the main results of the prevalence. So we had 10% or 10.2% of thyroid dysfunction in this unique hospitalized cohort. 5.4% were TSH between 5 and 10, means subclinical hypothyroidism. 1.5% were TSH above 10 or overt hypothyroidism. 2.1 were TSH between 0.1 and 0.35, means subclinical hyperthyroidism, and 1.2% were TSH less than 0.1 or overt hyperthyroidism. You can see here the patient's characteristics. We had almost 15,000 patients, their age was 67, mean 67, and most of them males, more than 60%. They had a medical history, as you can see here. So it was a cohort of cardiac patients. So we see here the hypertension in 2/4, in 67%. Diabetes in 33%, hypolipidemia in half of the cohort, and etc. You can see here that the main diagnosis at admission in STEMI or non-STEMI was 17%, in unstable angina were 10%, and a quarter of them had PCI during the hospitalization. You can see here the main results of thyroid dysfunction, and in the table, we can see here how many had thyroid dysfunction and which kind of thyroid dysfunction they had. The main significant risk factors for thyroid dysfunction in this cohort, you can see here were gender female, atroxine treatment, amiodarone treatment, CKD, heart failure, atrial fibrillation or flutter, and pulmonary hypertension. Most of the risk factors were found to be statistically significant even after adjusting for key variables such as age, gender, and medical history and medications. When we look at the outcome, so we can see here the outcome analysis for the two outcomes we looked for. This is the outcome of length of hospitalization. We looked on hospitalization that was more than 5 days. In comparison to patients with normal thyroid function, patients with either low or high TSH had longer length of hospitalization, more than 5 days, with the longest stay for patients with overt hypothyroidism, as you can see here at the right side of the slide of the table. For the mortality rate during the 12 years of follow-up, patients with thyroid dysfunction had higher mortality rate in comparison to patients with normal TSH. As you can see here, the normal TSH, and the right of the left, and the left, the others. Here also, the worst mortality rate was for the highest TSH levels at the right, but for hazard ratio, and as you can see here, compared to the group with normal TSH levels, the worst hazard ratio was for mild low TSH levels here, but it was very close to the very high TSH levels, like the hazard ratio was 1.4 each. This is the Kaplan-Meier's curve with the green line for normal TSH. The worst survival is in the group with TSH above 10, as you can see here, but also the 5 to 10 and the 0.1 to 0.35 were similar each other with bad survival here. It's very interesting that the very low TSH levels, which means overt hyperthyroidism, was very close to the normal thyroid function. Sure, the research has some limitations. It's a retrospective study, it's a one medical center, and there was a very, very big question about the option that it was CQ thyroid, what we call CQ thyroid or non-thyroid function problem that influenced the low TSH levels, and it was due to non-thyroidal illness. But we measured also in part of the cohort the T4 and T3, the free T4 and free T3, and we can see here that the low free T3s, that is typical first sign of CQ thyroid, it was in very low percent of the patients, and there were many, very few, only few patients with low T3 and low TSH. So all this, it seems that CQ thyroid is not a major player in these results. In conclusion, we can say that the prevalence of thyroid dysfunction in cardiovascular hospitalized patients in our cohort was 10.2%, and the higher prevalence of thyroid dysfunction was observed in female gender, in atrial fibrillation patients, in heart failure patients, in chronic renal failure, in pulmonary hypertension, and in patients treated with amiodarone. Maybe it was very, very important that almost a quarter of them had thyroid dysfunction. Also, patients that came with hypothyroidism and treated with levothyroxine, they had also almost 30% that they had thyroid dysfunction, and the dosage was not good for them. We think that screening for thyroid dysfunction may be considered in cardiology departments, especially for selected high-risk groups. More conclusions we can see here that thyroid dysfunction in cardiovascular patients is associated with longer hospitalization, and the longest hospitalization was observed in patients with TSH more than 10. Thyroid dysfunction is associated with higher mortality risk in a 12 years follow-up of cardiovascular patients. It's true that the study do not provide estimation whether treatment of thyroid dysfunction in these patients would improve outcomes. Future trials are needed to answer this question. At the end, I would like to thank my colleagues in the cardiology division and in the endocrinology unit. Thank you for your attention, and regards from Jerusalem and the Holy Land.